postgraduate student, they take it so beautifully inside their head. When it comes to the actual area of operation, they start panicking. You know, the moment they take the drills, you could get to see the Parkinson's syndrome, though they are not. One is because of me standing next to them, next to the anxiety they have. That's all. The same, it should be in line with the central fossa of adjacent tube. That is the placement. So these things can be assessed very easy. Can you see now? So we are beautifully allowing the force to transfer along the long axis of the tube. That is they talk so much about the biomechanical properties, blah, 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 blah. And can you see that the axis falls in line with the central fossa? This is the relative parallelism we established in placement of the pendulum. Again, that is in the premolar region. Axis hole restored in the patient's mouth. Now, second say surgical procedure. So you are all clear with the placement of the implant. Now you are placing the implant beautifully. You are going for the second say surgical procedure. Now, second say surgical procedure. What important that you needed to know is whenever you place the implant, make sure that you have a good amount of keratinase soft mucosa. Keratinase soft mucosa. They are the one who can form a healthy peri-implant seal. No connective tissue would form a healthy peri-implants. And remember, you can take n number of grafts, you can never develop whenever there is a severe resorption of the bone with a movable soft tissue which exists beyond 3 millimeters. All those cases, that's all we have clinical limitation of soft tissue excision. And that area we do not able to house the graft and have the placement because there is a change in the vascularity and the softness of the connective tissue will not solve the problem. So we do not have an universal solution for any particular illness. We needed to modify our techniques and skills based upon the clinical condition at the soft tissue level. At the soft tissue level. We take a radiograph now. Can you see that perforation image here? Now that is a typical type 1 bone. Type 1 bone, they have blood supply only from the periosteum from above downwards, nothing from below down. So in order to have the implant to get the vascularity, I just touch the periosteum, not perforate. I just touch the periosteum, allow the bone, allow the periosteum to bleed. I'm sorry. Permission granted? Yes. Sorry. So we allow the periosteum to bleed for the nourishment of the implant. Then we start going for the second stage surgical procedure. This is how it is. Do not ever disturb the keratinase mucosa. Be careful in exposing the cover screw. Select an appropriate healing abutment. Allow the soft tissue to heal at least for 2 weeks. Soft tissue resolution is must for developing a good emergence profile and peri-implant seal. Impression is made for fabrication of provisional restoration. நம்ம ஊர்ல யாரும் provisional restoration பண்றது கிடையாது. An additional cost. Yeah? Especially for the type 4 bone, we needed to conditional loading should be done. நீங்க பண்றீங்களான்னு கேட்கல சத்தியமா நான் பண்றேன். ஆனா காலேஜ்ல பண்றது கிடையாது. Because in the college we charge about 25,000 per implant. And an average of 2 implants we place every day. So this prosthodontic department of us is the goose that lays the golden egg. So another one based on the soft tissue thickness, we needed to decide segmented or non-segmented process. So that's explained to you everything clearly. Above mentioned steps determine the success of soft tissue profile and the function of the load carrying implants. Clear? Now, soft tissue profile forms a perfect seal. Not like your gingiva that is around the natural tooth, not like your periodontium, but in fact, to an extent, it allows the incursion of the fluid into the peri-implant site. Yes, we expose the cover screw. Now, these are the standard abutments, which we may use in the non-aesthetic demanding zone. These are the anatomic abutments with the dimension. The diameter starts from 4 mm, it goes up to 6 mm. to get the emergency room for. So for this patient, measuring the mesodistal width, it's about 10 millimeters. So I like that 5 millimeter diameter, so that we have equal amount of soft tissue to avoid that, the darkening embracing. So I waited for long to get for making that impression. Make sure that is not an angry red, it is a friendly pink. This is how it is. As I was ready to make the impression. Second stage in a partially lensless condition. Can you see that cuff? That's the most important thing that we needed to register during an impression procedure. And this was the time I was ready for making the impression. Again, I'm telling you, the scalpel works beautiful with everybody. You remain as an implanter. You want to be an implanter, you needed to be independent. Do not let anybody inside your clinic. So learn everything from the soft tissue to the hard tissue and to the biomechanical device. So, not necessarily you may have to have a soft tissue thickness of 3 millimeter. It can, if it is any loss because of the trauma, any chronic periodontal disease, you can increase the size of the healing abutment also. This jumbo one is a 6 millimeter. These type of cases. Can you see the marked one 6 millimeter here? So these are the soft tissue profiling now, multiple place implants in the anterior mandible. Maxilla, all these things are done in our institute. It is not grabbed from, cut, copy, paste. Now coming to the restorative phase. Now, implant type restoration, we have two type of processes, segmented and non-segmented. Segmented, simple English language, many components. Non-segmented, not many components. So in a segmental processes, we have an implant, and top of that abutment, and top of that we have a crown. Okay? And this crown can be reached either by mechanical means, that is a screw, process screw, or it can be reached by cement. We call it as a cementable processes. Now, what is the difference between these two? Whenever you are going to modify the customize the stock abutment given by the company to you that needs some modification, it should never be done in the patient's mouth. I repeat it again. Any stock abutment that has to be modified or the shape should be altered should be never done in the patient's mouth, because the titanium generates good amount of heat that is eventually going to affect your underlying bone, and also it injures the soft tissue. Recession so those type of, if you feel that you needed to go for a cementable option where it needs modification, you needed to make impression. That particular impression is made at the implant level. Yeah? Any modification that has to be done for a particular case, we needed to make impression at the implant level. So that the impression again makes impression made at the implant level, impression made at the abutment level. So what is the tray that we use here is, am I confusing? What is the thing that we are using here is two type of impression, at the abutment level and at the implant level. Yes? So when do you go for the abutment? Whenever you go for a multi-unit abutment, where it is a totally a screw retained processes, you make impression at the abutment level. Am I clear? Then comes the non-segmented. Suppose if there is no intraoperable space, especially patient with a class 2 division to flat mandibular plane angle, they have a short clinical crown. They are always a challenge through the crown preparation also. Those type of patients we do not have an intermediate component called abutment. Rather, we make impression at the implant level, have the processes direct